it's time to gather one more last exchange of ideas and expertise. Up next is a panel discussion. May I please call upon the panelists first? Dr. Shaijus P. Shaijas P. Dr. Harikumar. Dr. Ebi Koshi. Dr. Anita M. Dr. Venugopal. Dr. Rama Srijit. So this panel discussion today is now in the last leg of this advances is happening on the topic which is expectations from ultrasound reports in endometriosis and adenomyosis. Let us welcome our moderator, Dr. Nitin Chaubal and Dr. Selvaraj S.
Yeah, a very good afternoon. And unlike most of the panels nowadays, which are sort of pre-planned. The panelists know the questions, they know the answers. This one, the panelists are not really aware of what's going to happen. My co-moderator, Dr. Selvaraj, is from Malaysia. I just told him that for me, Malaysia was a second home because I go to the university very often. So let's see how it goes. So I'm the odd one out. I'm going to be on the receiving end because the clinicians are going to ask me what they expect from an ultrasound report. So with me, we have Dr. Sankalp, who is not there. Dr. Shayuz is there. And all of them are IVF specialists, are gynecologists. Dr. Hari Kumar is there, yeah, very much. Dr. Rema, no, she's not there. Dr. Venugopal is there very much. Dr. Koshi is joined last minute. And Dr. Anita M. Anyone have left behind? Me. Dr. Sheila. Okay, last minute. So it's like a cricket team. We have come together last minute. So, but I think we'll have a good show. So anyway, the idea was, adenomyosis and endometriosis both are very intricate topics, and we do expect a lot from ultrasound reports. As clinicians, they are right in expecting a lot from ultrasound reports, and as radiologists, I think it is right that we also give a right sort of report. The whole idea is just to sort of, outline what we expect out of the ultrasound reports. You like to introduce some?
I mean, in my country, I do my own ultrasounds, so I'm a bit biased. As I said, I'm learning a lot from the real ultrasounders.
Okay, so fortunately for us, at least, most of us do it. So as clinicians, let us start with adenomyosis. You must be seeing a lot of reports and you have to take a decision. So are you happy with what sort of reports the radiologists give you?
I think, look, I think all of us sitting here are people who do their own scans.
Oh,
so
that's sad.
That's a bit of a tricky situation. So
good, I'm not practicing in Kerala.
Yeah.
Otherwise, I would know what to do.
So the unhappiness comes when you have a radiologist reporting ultrasound suggestive of adenomyosis, or the other way, ultrasound suggestive of fibroid, and then you post a patient for surgery, and it turns
that's
out
what
to
we
be
discussed, and we'll discuss that
That's
more.
when the unhappiness arises.
And we feel that because we are into a very narrow specialty, we tend to be seeing more. We might be not as qualified technically as a radiologist, but because we see only the same set of patients,
Exactly.
we get the findings much more accurate most of the time. So sometimes you do have to contradict what has been given to us, and we have to sort of tell the patient, look, this could be something different. Both of them look very similar, but to the trained eye, you might see something different.
And in Kerala, the special situation is just because we gynecologists do our own ultrasound, it doesn't prevent the patient from going into a radiologist and getting a scan done. So she comes with 3 reports, which has already been done. I have to give the 4th opinion. So the trigger for me to evaluate that uterus further is the report of a radiologist.
And invariably, a
Yes,
report from
actu-
a radiologist in Kerala will be ending up with please correlate with MRI.
They'll always write.
It's always be there.
As I said, I'm going to be at the receiving end.
No, actually, it's like backseat driving because we see all these patients more. So we think, or we feel, or we think we are better in this.
Okay, but I think as imaging people, I think definitely there is, we have an advantage over things because, our life is on imaging, so maybe few things here and there. So what we'll go through is, what sort of things we expect and what are the current guidelines which are important.
So, main.
Yeah.
You have the advantage of being an imaging man, but we have the advantage of clinical correlation. We are seeing the actual thing in the surgery
Yeah.
and correlating it with the pathology.
Yeah, but we have good friends with gynecologists who give us feedbacks as well. Anyway, so how common is this problem and why it is very important to diagnose correctly? I mean, briefly, any one of you can.
It's quite common nowadays, actually. I think previously we probably because we were not doing so many scans at that time, but now in the young, we're all most of us are, I think, infertility people. So we are all seeing a lot of adenomyosis in the younger
Unexpected.
ages. Very important because especially when you're taking women for IVF and all, implantation failure, all these things, and differentiation from fibroids, whether to do surgery, all these things.
Many a
Mostly
times
the
it's
pathology-
pain. It's pain that the patient is seeking an answer for. And then, many a times we find that, even in, like she said, in young patients, it's an answer that you can give the patient that this probably is the reason for your pain because, yeah.
And thankfully, because there is so much of discussion on how imaging still remains relatively inadequate in diagnosing adenomyosis, there is, I mean, those cases which used to be labeled as abnormal uterine bleeding without any cause. Many a times we are attributing that to adenomyosis now, and as well as the pain-related recurrent implantation failures, which did not have any reason before. I think we are more and more concentrating on the myometrium, how it appears, and
So
all that.
with, I mean, the awareness is increasing, the incidence is increasing because of the awareness is increasing, and number two is we have, of course, good machines in
We are
ultrasound.
overdiagnosing a bit also might be there. I
Pardon?
don't know. Whether we are overdiagnosing also, I think sometimes because in
Yeah.
abnormal uterine bleeding, you see one area of this thing and then I don't know whether we are, because we are always looking for that.
So we now have definite criteria whereby you can call it adeno or not adeno. So I mean, just in brief, what people propose of so many theories of why it comes up. So could you just sort of briefly say, I mean, what is the pathogenesis of, because most of the ultrasound features which you see on ultrasound you can correlate based on how it happens actually.
Yeah, theoretically, any invasion of the endometrium into the myometrium will be termed as adenomyosis. But there are other theories like repetitive injury of the junctional zone,
Yeah,
leading
I
to
think,
increased
yeah.
estrogen, and the embryological theory.
Basically
the classic-
invasion, no?
Invasion.
And it's evolved from inside to out
Absolutely.
to outside to in. So, sort of that evolution has taken place. Young people, you can't explain why there should be some trauma or there should be. Classically, we used to always believe that, endometrial cells into the
Yeah,
myometrium, that sort of thing. But then that doesn't explain how a young patient or a patient who hasn't had childbirth or who hasn't had. So that's evolving in that direction. That both.
So basically, we have this endometrial myometrial interface, and the difference between an endometrial myometrial interface as opposed to other body organs, like for example, stomach, or intestines, we have a mucosa, submucosa. Here we don't have a submucosa. We have a single line of defense. So I will say, like, China has two walls, whereas India, Bangladesh, there's no wall. Between USA, Mexico, the wall is weak. And whenever there's a weak wall, the endometrial glands sort of infiltrate into the myometrium. And like here we can see almost something which is just about to go inside the myometrium. And these are typically, that's why they are cystic area. Now, once they go there and settle, like, then, what is an enclave? Enclave is a part of a country in the other country. Like we have in India, there are parts of Bangladesh, and in Bangladesh, there are parts of India. These are people who have migrated from there and here, So now, of course, these have been sorted out. So once they go and then settle into the myometrium, they settle down there, and we call them islands or hyperechoic areas, which are islands. So the pathogenesis and the features of ultrasound actually correlate very well, and then it is very easy to sort of diagnose. And as I said, there is also an outside in theory. So we have this adenomyosis, which comes from outside, typically seen in deep pelvic endometriosis, where you see what is known as a FOM or adenomyosis coming from outside. So both the things, are known. You like to add something?
Because I'm doing HIFU, I do a lot more MRIs now, and I'm learning more and more about adenomyosis from the MRIs actually, to correlate it with the ultrasound, and actually you learn far more, and I think you'll be showing later there are different aspects of adenomyosis, focal, internal, external, which we probably go through it.
So most of the pathological features which we talked about can be explained on, the ultrasound features which we expect to see can be explained on pathogenesis. So, could you, we have these parts of adeno part, the meiosis part, and the vascular part. So, I mean, could anyone just sort of, it's there, but
No, basically, adeno means glands outside.
Glands
in
coming out,
stoma.
correct.
So those will be seen as cystic areas, and whatever secondary to that, biometrium becomes hypoplastic. So they will be shown as thickening of the asymmetric thickening.
biometrium.
And obviously, vascularity will be increased, so it will be translational.
Yeah, so we have an adeno part, which is those endometrial glands, and this gives rise to what are known as cystic areas or the islands which you talk of, echogenic striations. Then we have myometrial thickening, which is a very essential part. And then, of course, we have vascularity. And when all of them comes together, we have a cirrhotic uterus. So uterus looks like a cirrhotic liver. So we call it cirrhosis of uterus in our terminology. And this is now explained by what are known as MUSA guidelines. So we have some direct and some indirect features. So someone can enlighten on some of the direct features which we see on.
Yeah, direct signs means you are sure that there is adenomatic invasion. These are cysts, that hypogynous bands, and this subendometrial bloods and lines and buds. And secondary to that, because of the presence of these, we have the indirect signs, that is asymmetrical thickening, globular uterus, fan-shaped, this Venetian blind, and the junctional zone, which is seen only in the 3D or MRI. And
You will always mention about the transition zone.
Yeah. So we'll come to reporting. Yeah.
Yeah,
So-
and these individual features were actually known even before, but now I think this has Paul put together everything. Now we know exactly what to look for and how to come to a diagnosis. I think it's been pretty much streamlined now.
Absolutely. So, for example, cysts. Earlier days we used to see cysts, and we used to say fibroid degeneration, this, that. But now we know that a cyst within the myometrium is adenomyosis, and whether the cyst is single, multiple, round, irregular, it does not matter. Shape, size doesn't matter. These are again diagnostic, hyperechoic islands. So if you see these echogenic islands, they're again diagnostic of adenomyosis. And the third thing, which is of course diagnostic, is this echogenic subendometrial lines and birds. So all these three things, when you see or you see individually, you make a very confident diagnosis. So the whole idea of the MUSA guidelines is to streamline sort of the diagnosis and use the right words, which is very important, rather than use vague terms like that's very important. And then, as he said, that because so many things are happening, we have some indirect signs. Yeah. So we have we have this globular enlargement of the uterus. The entire uterus becomes large. We have another very diagnostic feature is this asymmetrical thickening. So normally you see one part of the uterus which is very large and the other part of the uterus not as large. So this asymmetrical thickening is again a very diagnostic thing. And then when you have a deep pelvic endometriosis, the uterus becomes retroverted. The fundus goes down, and this gives rise to what is known as a question mark sign. So these are again very, very reliable signs. And then this Venetian blind sign or fan-shaped shadowing, again because of these linear striations. So these are the words which are to be used in our reporting, and as radiologists, this is what we do, and so that there's a uniformity. And as I said in my previous talk, that the vascularity in adenomyosis is translesional. It is within the lesion that you see multiple vessels, and not like the fibroid, which is this thing. Then this is very important. We look at a junctional zone, and we look out for any irregularity of the junctional zone. And number two is interruption. That means if you look at the junctional zone, suddenly there is a give way. Of course, depending upon the situation, age of the patient, we also need to think of malignancy whenever you see interrupted or interrupted junctional zone. But these are the classical signs. And then finally, the uterus becomes sort of cirrhotic. So any comments on the ultrasound features, direct, indirect?
Just the interrupted, that is, many times we see, sometimes it's irregular, but sometimes you get these interruptions, especially near the fundus. So it may be sometimes difficult to differentiate from adhesions, especially when it's not a very thin, it's very thin, and you have this breaks in between. So intrauterine adhesions.
Intra and synechial
Synechial
or
also could be
adhesions
the
can
same.
mimic that, right?
No, as clinicians, we are always trying to, most of us are infertility people. So we always like, we're looking for that symmetry, like for example, we would like to know whether that adenomyosis is focal or, it's diffuse. That makes a difference to the way we manage it. So we are always looking at a proper diagnosis. We want to know whether it needs to be managed by surgery, and we want to know whether it has an effect on implantation. So I think all those terms help in that direction. We are looking more for the Venetian blind appearance. I think most of us have it in our mind ki chalo, when we see that is adenomyosis. Then the transition zone. So practically these are important. Focal, yes, that makes sense to us then.
The interruption of the junction zone, I don't always rule out a history of any uterine surgeries prior.
Absolutely.
Because
As you said, Sainiki.
yeah, when you actually, very true,
And
very
secondly,
important to rule
in
out.
an elderly patient, as our oncologist friend said, always keep that possibility of
True.
endometrial malignancy.
True.
Whenever you have interrupted
A
endometrial
cavity which is
malignancy,
not
very important.
reconstructed well after maybe a myomectomy surgery which was done years before, which people would have actually forgotten. You will have to really find out from the history.
And though it's
Can I ask you all, if you make the diagnosis, say you see this break in junctional zone or Venetian sign or whatever, it's not so big uterus, how will it affect your management of the patient?
No, because most of these cases where the junctional zone is interrupted and very thin, those are the patients where we find difficulty in implantation. So how will it affect? So we know there's going to be difficulty. The management is another cup of tea.
You just pre-warn them that your
No, we
chances
can't-
of pregnancy is low.
No,
And
but
then get away with it.
Exactly. You can have a bad result at the ART, and second thing is pregnancy, early miscarriages and
Early
preterm. So
miscarriage.
you have to warn them.
And though it's pretty obvious, I just wanted to emphasize that these are all TVS images. A lot of people are hesitant to do TVS, both doctors and patients. So you might miss out on a lot of things.
Why? But
No, it happens. People, you go to a place, they are doing an abdominal scan, they just continue with an abdominal scan. They don't really go into a TVS.
yeah. So at least in our center, I mean, usually married, of course, there's no problem. If a patient is not married, we do transrectals. I mean, we convince the patient that this is very important for you, especially as we'll talk of endometriosis. And here also, we have small transrectal probes, and most of the times the patient will be convinced. And you can do as good imaging with transrectal ultrasound as you can do with transvaginal. So under the present circumstances where we have wonderful probes which are very small, I think for both these conditions, I think transabdominal should be no. And if you convince the patient and talk with them, I think most of them will
In
agree.
Kerala, there are certain areas where if you are a radiologist and if you can see everything from above, you are considered to be superior.
That's
Especially when people are relatively hesitant to get. It's not just about a man or a woman who's doing the scan, but you are expected to be superior. So I think the thought process need to be totally.
You will tell me where I'll go and teach them. So we come to the crux, and most of these points is ultimately what are the things you expect from the ultrasound report? What are those 1, 2, 3, 4, 5, 6 points?
As I think rightly said by I think both of them, the initial discussion, we are always looking to see whether is there a lesion which we can resect and repair and make it better, or is it something which is so diffuse that no surgical intervention is going to make any difference, so it has to be medically managed. And number 3, I think the question that we need to is what is the complaint that patient is coming with, and is there a correlation that I'm able to find with this particular diagnosis being made? If that makes sense, then it really adds on to patient care. So one is about is there anything that can be resected, or if it's too diffuse to be only medically managed and nothing else can be done, and the correlation with her symptoms.
So what do you mean to say is that coincidentally you pick up adenomyosis and some big complaints, patient is not having pain as such or anything, you would think in a different line as far as management is concerned, right? Would you like to add, Selva?
Yes, I think that's correct.
No, and definitely the confusion between fibroid and adenomyosis.
Yeah, that
Fibroid,
is-
you put in for surgery
So
and you don't
from
know
tomorrow that problem is not going to come because we are talking of multiparametric ultrasound where we have elastography, contrast.
If anybody feels this discussion on sitting and discussing about ultrasound features in adenomyosis out of place, I think you just have to get on table and operate one adenomyoma, thinking that it is
It's a
fibroid.
fibroid. And totally
And
agree with
the end of that surgery, you will realize how important this discussion is all
Absolutely.
about.
But then when you have a doubt, I think what we do is usually counsel. There are some times where you get a very difficult to distinguish. It
So we'll
will
come to that
focal
again.
myomas, adenomyomas.
So I think from the their point, surgical point, or the clinician's point, first is of course it is adenomyosis, whether it is fibroids. Number one, location, diffuse and focal, as you said, whether it is focal or diffuse. The cystic, non-cystic, we'll come to this. Which layer of the uterus is involved? Because from the point of view of conception, extent and size. So as per the MUSA guidelines, also you have to report adenomyosis in this way, and this is what we do in our center. We have a chart, and all these points are correct. So location, of course, again from surgical point of view, important. So we have charts like this, just like fibroids. So we put the location anterior, posterior, right lateral, left lateral, whatever it is. And I think they pointed out that it is very difficult, important to differentiate the focal from diffuse versus an adenomyoma. So how do you sort of go about this? Focal adenomyosis versus diffuse. When do you say it's diffuse, or when do you say it's an adenomyoma? Is there any criteria, or yeah?
It's when it's more than 25% surrounded by normal mammitrium. It's like focal, and if it is more than 25%,
Less than 25%. So if you see good myometrium around it, more than 25%, that means it's well contained. We call it focal. Here you can't see any myometrium. There's hardly any myometrium. So this is classically diffuse. And if you see a thick myometrium around it, we call it and this is the one which mimics fibroids the maximum. Yeah.
And then most of the times, even when we find something focal, I think there is always a diffuse component elsewhere.
Yeah,
so I
that's
think
true.
we also need to have a very clear idea, especially if you're planning for a surgery. On what are we planning to, just like we do a fibroid mapping, I think there has to be a very clear mapping for this, at least mentally, on where you're planning to make the incision, so that you have a fair idea by doing your own ultrasound on where the incision is being made, because otherwise I think the radiologist should be considerative enough to actually give you a proper mapping of where the adenomyoma is located. Otherwise you are in a soup, because see, in fibroid, even if you don't place your incision well, you can always extend a little bit and then you will find out that there is a plane where it will pop out. But this is not going to be that
absolutely.
way. There's hardly going to be any clue once you make the incision. So before you make the incision, you have to be very clear how much you're planning to enucleate out, or can't even call it enucleation. You're almost chopping it off and then reconstructing the uterine wall. So I think you need to have a very fair idea. So if there is a diffuse component, ensure that you're not going to touch that. And if there is a focal component, mark it well, map it well before you actually do the surgery.
That's right.
Actually, one thing that will help here is the vascularity. Differentiate. I think that's the most important thing. If you have the typical circumferential and the translational vascularity, be wary of it. You can land sometimes be a.
Correct. So I think we should have more radiologists in this from Kerala also, okay, where we can. So is this cystic, non-cystic, is it important for you?
Yeah, especially those acute juvenile ones, which are actually will be helped with surgery, because they are very good results with surgery. So we have to identify the cystic lesion.
So which
there,
ones are cystic?
There was a talk earlier, Dr. Asha Rao. She mentioned a specific case of cystic adenomyosis. That means an globular one, full cystic, where they just did a surgery. They aspirated that cyst, and then they gave a depot of GnRH, and then subsequently the patient conceived normally, she said.
No,
That's
this
all.
actually happened in adolescent kids.
Yes.
So probably we may
Younger
not be able
ones
to
have
add
more.
transvaginal.
Yes.
So and extremely painful, and will be totally relieved
Correct.
with the surgery. So it's very
Correct.
important to identify that.
So cystic is more common in juvenile
Yes,
patients, that's
yes,
what you're
yes,
saying.
yes.
That's right.
Those.
Very good. So that's again very important. And then the layer involvement, how important is this? Whether it's layer 1, we call it junctional, middle myometrium, we'll call it 2, and outer, we call it 3. So just like fibroids, when you have a phagotype 0, 1, 2, 3, 4, 5, we are familiar with that. So if you have adenomyosis which is extending say from 2 to 3, then we call it type 2, 3. That means it is extending from 2 to 3. So I think all of you would agree that this is one of the most important things.
Yeah, so again, sir, the typing 2 very important again. Just like I was talking in the lines of surgery, when you make the incision, you have to be very clear to what depth you have to reach. Otherwise, because there is no plane, all these tissues almost look similar. It is just like that cirrhotic feel, no, that you generally get. It's all bizarre, and you never get the architecture of a normal myometrium and all that. So unless you really know to what depth you need to reach, how close you are to the cavity, it's very difficult to actually plan this. So I think this is another key feature which has to be planned out well if you are planning to operate.
Very important, right?
Yeah,
Yeah, yes, ma'am.
isolated lesions like this, I think it should be more of medical management than surgery.
The ones
Only
which
if
are-
you have a diffuse, you should think, because it's going to disrupt. Yeah.
No, madam, the reverse. No, we are not talking about whether this particular lesion has to be operated, because there are a lot many other things to consider when you decide to really
When it's
operate.
painful.
Yeah, yeah, but generally it's not the diffuse one that goes for surgery. Diffuse one, there is no role for surgery.
Absolutely.
You should have a very proper lesion which is seen
No, I'm
where you think it will
talking-
make a difference.
Talking of this type 2 when they showed,
Okay.
sometimes you have a lot of, very difficult to find, and sometimes the plane, not the plane.
Okay.
one thing
Plane
about
is not there in any of these,
diagnosis
basically.
is also at times difficult. You really don't know whether it's a small submucous fibroid or it is in, there are a lot of times we have a, but then if you see the uterus
Because it's
in
on the
toto,
middle layer.
in toto, we are likely to find other areas of adenomyosis.
Contour.
So type 2 management is always a little
Difficult.
bit difficult.
Right. So what madam is saying is that this is because it is in the mid myometrium, it is sort of difficult. If it comes on the outer side, you have some focal bulge there or something of that sort. And then of course, as I think all of you said this again, extent and involvement. So again, here we have now well-defined sort of criteria. So anything which is less than 25% of the whole thing, we call it mild, 20-25% affected, and severe is more than. So these are just guidelines, but what is important is that these points should come in the report, mild, moderate, severe. And then size of the lesion. So if you have a focal lesion, we measure the largest size, and if you have a diffuse lesion, then we measure the largest thickness of the myometrium at that point. Because especially here, it's not possible to give the exact size because most of these are diffuse. So we will give the maximum thickness of the myometrium, and when you see something which is more localized, then we can give the maximum size. And then of course,
So
this
just
is
on a lighter vein, I was just thinking that your gynecologist in and around your place, no, need to be really knowledgeable people. Because I don't think if you give such a detailed report, they would be understanding what it actually is. So hats off to that wonderful effort that you have taken to actually.
Yeah, I think we have very good rapport with them. You know, like
No, so the catch thing is that, without any offense to you, I think adenomyosis need to be diagnosed by the infertility specialist. You need such detailed reporting only if sir is doing the reporting and I am watching it. So, because all said and done.
the best thing is I don't mind, but the best thing is when you people do, you don't give reports.
No, sir. No, that is not the catch. The catch is that if we are not able to diagnose, then we'll maybe send it to you and ask what do you think about this.
That is why even in this panel, when you are asking questions is in different mode. Finally, the answer comes to whether you have to resect or not, or whether you can give medical management, or it leads to any symptoms. That's all.
Yeah, that's fun.
That's for your survival.
Yeah, I know. So that's what I said. Good, I'm practicing there a lot here. Then, of course, this burning issue of fibroids versus adenomas, and we touched upon this when I did my talk on multiparametric ultrasound. This is probably the most important thing, and we use newer techniques for that. So we said, look at color Doppler, look at this classical pattern on color Doppler. There is a classical pattern on this thing, and we use contrast. A lot of people were asking me what contrast we use. It's very easily available. It's known as SonoView. It comes in a 5 ml vial, and we use it for so many things: liver, kidney, and gynec is, by the way, like this because we require less amount as compared to kidney.
How do you use
where
it?
do you put
Can you
the
just tell us how you
contrast?
use it?
So it's a vial which is a powder form. So basically these are gaseous agents. It's a powder, and you have to mix it with saline just before you use, and then you shake it for 20 seconds, and then so these are basically gaseous agents, and then you inject intravenously, typically anticubital vein with 20 number needle. Yeah, that's it. But there's no nephrotoxicity. They're very safe because they're excreted by the lung. They're not excreted by the kidneys. So you don't have to do creatinine, anything of that sort. So we use it extensively for liver, kidneys, and of course we use it for gynec, and we do a lot of hycosi with that. And for tubal patency, you can use contrast which is 3, 4 days, 5 days old. For IV, typically we use, so my wife is a gynecologist who is now doing ultrasound. So I have a soft corner for her. So whatever I use from liver and kidney, I give it to her. So anyway, but it's once you start using, you really, you get the
Will it help you whether it is focal? That's what the capsular. What do you
capsular.
There is it's
So
it's a sort of
typically, this is
enhancement.
in a fibroid, for example, you
Yeah,
see
just
this
the same way.
basket
Yeah,
pattern,
so you get that.
and here you see mosaic. It comes from within, so that pattern is entirely different. And elastography is, I think, available in most of the machines. So that is something which again you can use. So this is how we report, at least in our center: location, differentiation, layer involvement, type, junctional zone, size, and of course extent of the disease. And so I think that is what helped.
How much you charge, sir,
For the
for the one ultrasound?
for the contrast?
No, for the ultrasound.
For the ultrasound?
You're taking so much pain.
Okay. No, I don't remember.
How much is this
Vial.
costing?
Okay, so the vial cost is about 6,000 rupees with taxes, but we can do at least 4-5 patients in that. So
I think the problem with the SonoView is you need a special software in your machine. So you got to pay for that software to use it on the machine. That's
but
the
when you
problem.
buy the
So
machine,
No, it's
but-
different. Because I have a very high-powered machine, but it doesn't have that software, so I cannot use it. So, but because I do HIFU, I also
Sure.
use SonoView to view and burn and also look at it. So, and another point about SonoView, we use another drug called Sonozoid.
Sonozoid.
It lasts in the body for 3 hours.
Yeah.
So we use the bubbles to cavitate the fibroid. That means we actually burst the bubbles so that the tissue dies. So that's another way we use it.
So the difference between Sonoview and Sonozoid is Sonoview is a purely intravascular agent. So it goes to the circulation and lasts for about 12 minutes, 15 minutes, whereas Sonozoid goes into the outside the tissue. So that's the difference between them.
You said about HIFU. If you could just tell us a little bit, we were just wondering that how is your experience with it for adenomas?
I gave a 1-hour lecture just now, yesterday.
just
We-
we were there.
the basic concept is using ultrasound to kill the fibroids. That's basically, it's a big machine that focuses the ultrasound to kill fibroids and adenomyosis. So that's the reason why I learned how to use SonoView and Sonozoid. Yeah.
So in Jaslok, we probably did the largest number of HIFU for fibroids. And HIFU is now used not only for fibroids, focal adenomyosis, you can use HIFU, but it is also being used for brain, like Parkinson's disease, incoordination, etc. Okay, so we go to the next burning issue, more difficult, as he says, on endometriosis. Again, what is important is, and all of you are aware of how bad is the problem, etc. This is important, I think. So, as clinicians, how do you choose the imaging modality when you suspect endometriosis?
Always transvaginal.
Always transvaginal.
Yeah.
Always.
So,
Very rarely anything.
very rarely
Anything else? Yeah.
beyond that. Yeah.
Something very, very rarely you need.
Yeah. So as I said earlier, in our center, if we suspect endometriosis, even if the female is unmarried, fortunately my wife is with me, and I've got a team also with a lot of females. So we convince them for transrectal ultrasound, and transrectal does wonderful job in endometriosis because you are in the rectum, you are on the rectal wall. So especially for deep pelvic endometriosis, it's really wonderful. So even if we do transvaginal, sometimes we add it, complement with transrectal.
You need an extra preparation.
Even nowadays, because we promote a lot of this use of menstrual cups and all that,
Cups.
we are able to convince them to do even a transvaginal. It doesn't become so difficult.
Yeah.
The conservative patient is always conservative, but
Yeah.
otherwise it's slightly more easier nowadays.
And we have a lot of
So hope you
unmarried-
got the point, sir. Basically, so
Yeah.
they need not be unmarried for you to do a vaginal scan.
Yeah.
I think.
So what is, just can you tell me about this?
No, what he meant is that because menstrual cup use is so common,
Okay.
even these unmarried, they're all willing to undergo transvaginal
Okay,
scan.
okay.
That's one thing. But as you said, DIE, rectal is really, it does add to the benefit, especially when you have a nodule and all, isn't it? Rectal nodule.
So what about the preparation for the rectal ultrasound?
Same, we don't have to prepare.
Okay.
For endometriosis, people suggest that you do bowel preparation in general. But
specifically-
if it is you are doing a general rectal ultrasound, because the probe, I mean, it doesn't go deep or anything. It's just right. So as all of them said that ultrasound is the first modality, and they would add something more like an MRI only in some cases, right? Especially when it's PI. So I mean, since I'm a sonologist, why ultrasound is because whatever you say, whatever Tesla machine you have got MR, the resolution of ultrasound is still superior to MR and CT. This is a misconception. A lot of people have that CT and MR have better resolution, which is not a fact. Actually, ultrasound, because of the higher frequency, you're going close to the area of interest. And number two is that no other modality is real time and dynamic. And in endometriosis, this is the most important thing. Is the ovary moving? Is there uterus sliding? I mean, all these things are most important. So therefore, the first choice is always going to be ultrasound. And then, of course, we said that we have newer techniques which will help us. So some people, you feel laparoscopy should be used as a diagnostic tool for endometriosis?
It was once upon a time considered to be the gold standard, but now no more. I think we're very clear that we shouldn't end up with a case of laparoscopy, put in a camera and surprisingly find that there is endometriosis. I think that scenario should never happen now.
Correct. That's another very important message that as of today, when it comes to diagnosis, I think first is ultrasound, and only then it is. And sometimes, of course, laparoscopy can miss some of the deep pelvic endometriosis because you're looking from the top and you have something which is down. Absolutely. The only place is maybe superficial endometriosis, which ultrasound may not be able to pick up, right? So we'll come to correct reporting, and I think most important is you would say that you need to not only plan what team you need, like you might have to have a urologist if required, or a rectal surgeon, and what type of surgery is required. So it's very, very important to stage correctly before doing anything. So can you anyone can highlight on this? We have something like known as IDEA guidelines. So
they came up with the systematic way to do it, because you have 4 components. Go for the regular one for the uterus and the adnexa, and then go for the soft markers like site-specific pain and ovarian mobility. Then look for the sliding sign in pouch of Douglas. Then to the deep lesions in the anterior and posterior compartment.
Why it's probably important is generally what we do is we have a transvaginal ultrasound. The moment we pick a chocolate cyst, we are mostly done with it. Then what we do is we look for a little bit of retroversion and finish off with it. But now what's happened is that there's an explosion of on social media surgeons doing a lot of endometriosis cases, and then it seems that they are catching so much of rectovaginal endometriosis and this thing. So it's prompting a rethink as to whether we should go in this and whether we are missing out on the other steps, like whether we are missing out on deep infiltrative endometriosis and this thing. So I think that's why this has come so much into it now, and that is one area where I think even as fertility specialists we are a little bit lacking, because we get satisfied with okay, I saw a chocolate cyst, then the ovary is adherent, and then uterus is retroverted.
On the other front, we are also worried whether unnecessarily are we digging deep in a patient where it is absolutely not indicated. So whether such ultrasound reports, whether it will prompt more people to dig deeper when it is actually not required. So there is always a way to go conservative in a case of endometriosis. Even when we say, I'm not talking about deep invasive endometriosis. I think majority of our patients do not belong to that category. Deep endometriosis, especially when pain is the leading symptom, and only a resection of that particular nodule and a complete surgery, only that can give pain relief. Otherwise, putting in a laparoscope and then burning a few things here and there does not at all benefit that patient who's suffering from a deep invasive one. Keeping that in mind, there are other patients who actually do not require such kind of deep dissection and removal of the disease as such. Because we have found that even spontaneous conception is very much possible with a least minimal adhesiolysis, getting your tubes intact, ensuring that your ovaries are mobile enough. The least minimum amount of treatment is good enough to make the patient pregnant. Absolutely. So do not at all lose your belief in what the nature can do by doing less intervention. Always keep that in mind. At the same time, remember that small subset of patient who will not be benefited by the superficial kind of surgeries that you do, who will require a resection of the a nodule if it is there, which is causing the pain in her. So I think this both sides of this coin need to be addressed, and you need to follow
Counsel
a
the
very,
patient.
very sensible path. Do not investigate and image too well, which makes you think that everything you need to resect out and then make it better than what God has already created.
I think very important message.
Yeah, because patients get worried also.
Is it? Okay.
When they get very detailed reports, especially the patients also, they get extremely worried, and then I think that's what happens. Yeah, in Bombay, the same thing is happening.
And we need to agree with the fact that a person who does endometriosis surgeries is actually a more skilled person. But this should not be a reason for them to show off
Their
their skills.
skill. Absolutely.
Absolutely.
I think it's very, very important point. And I agree with you that these things, I mean, we do see such things. Another very important thing is, besides, we'll go through these steps because they're very simple steps. I mean, so maybe if you are doing your own ultrasound, you could follow these steps. Number two, very important, and this is where I think you should not be doing your ultrasound, is after seeing this, it is very important to put the probe on the abdomen. So that's very important. In fact, I'll show you one case where we picked up ureteric endometriosis only because we saw hydronephrosis. And then we traced the ureter, then we did again transvaginal, and I'll show you that case
That
also.
criticism is accepted because that's true. That we sometimes don't fail to look at the kidneys and the
Liver. We have seen a liver endometriosis, surface endometriosis. So, there. So we'll go through these steps. The other question is the patient preparation? So there are two thoughts about it. Most of them come unsuspected, so there is no time. But if you feel that this patient has definitely come for endometriosis alone, maybe you could do a bowel preparation. But in day-to-day practice, honestly speaking, we don't do. It's a good idea, especially when you want to see which layer of the bowel is involved, which layer of the rectum is involved. You can ask for a patient, or maybe if you feel, you can ask the patient to do a bowel preparation and come back again. Number two is, when we do transvaginal ultrasounds, we keep the bladders empty. Here, we would like to keep a slightly full bladder because we want to see the junction between the uterus and the bladder. That is where we see it very often, and you want to see the ureters, the terminal end of the ureters. So don't totally empty the bladders, keep a slightly full bladder. What is slightly is difficult, but that's the thing. So, as we said, that there are direct signs when you see the endometric patch, and there are indirect signs which are based on addition. We'll go through these steps just one by one. The first step is, of course, looking at the uterus and the ovary and picking up endometriosis. This is a classical appearance of endometriosis, which is like these internal echoes, and then we see these echogenic areas here, which is again very, very typical of endometriosis. So this is one more issue, is there something like, can ovarian endometriosis be isolated, or you think it is always
occasionally
Yeah.
yes. Occasionally yes, yeah.
occasionally, or
There could be, yeah. There's no rule as such that
it has to be associated with that, absolutely. But some people, I think those aggressive endometrial surgeons believe that always with ovarian endometriosis there is endometriosis somewhere else. But that's a different issue altogether. So that is the first step. The second step is soft markers. That means you put the probe, you ask the patient, idhar pain hai kya, idhar pain hai kya, that will lead to it. And we look for this ovarian mobility with the help of the probe. And if you see kissing ovaries, that means both ovaries in the pouch of Douglas, both ovaries very easily seen, this is indirect, very reliable sign of adhesions.
And these kind of findings are so very important because you can always, especially if the patient is one who's seeking fertility, you can give them some realistic ideas on what their future is going to be. Is there a real chance of or trying to conceive naturally? Are they going to get pregnant with this kind of picture where the tubo-ovarian relationship is so badly damaged? And you can actually pick and choose those patients where an adhesiolysis can actually be magic. As far as their fertility is concerned. So that is also why these kind of imaging signs are quite important.
Correct. Then of course, then the third is a sliding sign, and this is for pouch of Douglas. The way you do the sliding depends on whether the uterus is anteverted or retroverted. So you put the probe, and if you have an anteverted, we'll push the fundus from the top with the finger, with the thumb. And if you have a retroverted, we will put the palm. So this is suggested but you can have your own way. But it is very important to see the entire pouch of Douglas, because this is another, as we know, one of the common. So that's a classical pouch of Douglas endometriosis which we see. And one more technique which we use sometimes is what is known as sonopodography. So typically, as I was saying, Dr. Jayakrishnan, that we do a lot of these saline sonographies and tubal patencies in our center. So anyone who wants to learn, HycoC or tubal patency, most welcome to come to our center. So during that process, when we put saline, there's a lot of saline which goes in the pouch of Douglas. And sonopodography is nothing but taking advantage of that saline in the pouch of Douglas as a contrast to pick up those small nodules in the pelvis.
When I saw this terminology, I was thinking, where does this podo limb element come? Then only I realized that it is POD, sonopodiography.
Okay, so pouch of Douglas graphy, it is like that. So then, as for example, the retrocervical area you could see better once you do that. Then we go to the anterior and posterior compartment separately. For anterior compartment, as we said, this is, you look at the bladder base, the interface, and of course the ureter. Nowadays we see a lot of scar pregnancies, post-Caesar scars and endometriosis in the scar. So again, this area is important from that point of view. So here we have a utrovesical fold endometriosis, which is very vascular. This is a scar, LSCA scar with endometriosis, again very important. And this is a case I was telling you that initially, we picked up ovarian endometriosis, we looked at the kidney, hydronephrotic, then we traced down and then we picked up a nodule which was causing obstruction to the ureter as well. And then at the end of it, it is always a good idea to make a chart. For the posterior compartment, again, we do go step by step. So another new technique which we use for the vaginal wall and the recto-vaginal fold is what is known as gel sonovaginography. So what we do is we put a lot of jelly in the vagina, KY jelly or even ordinary jelly, and then put the probe on the top. So with the result that this vaginal wall is seen very well and the vaginorectal septum is seen very well and the posterior fornix of the vagina is seen very well. So here, for example, we have this patch of endometriosis. We have put a lot of jelly. You can see both the vaginal walls very, very clearly. So this is nothing difficult. You just put a lot of jelly there and then put a probe on the top and you can see that. Then of course we look at rectum, different parts of rectum. We judge where it is depending upon how much is the depth from the anal vag. So there are some signs of bowel involvement, like we say absence of spikes, tail comet, Indian headdress. I'll just show you one or two slides and you'll get familiar. So this is classical of the endometriosis on the rectal wall, and all this comes up because of the patch and also because of the fibrosis which comes up. So two signs which are very familiar is what is known as Indian headdress sign. So this is it mimics the headdress of an Indian. So that's involvement of the rectum, and a moose antler sign, which is again very typical. So this for example, in this patient we did a scopy and it was almost mimicking what we saw on ultrasound. So that's gratifying. And then for uterosacral, there are techniques. One which we use is we go to the torus and then we sweep the probe on either side. So in our center, it's a good idea to try and look at all uterosacrals. Whenever you do transvaginal scan, it hardly takes 5 seconds more. But it's a very good practice to look at uterosacrals. Even if you don't have endometriosis, actually that's what we tell our fellows. But with good technique, you can see them very well. And then if this is again very important for all of you, that if there is a nodule sitting there, it is very, very important to report. There is a very extensive classification which MRI people use, NZN classification, but and there are various ways of doing it. So in essence, what we want to give in our reports, and we hope that it comes in our reports, are these questions. Is there ovarian endometrioma? What about ovarian mobility, site-specific tenderness, anterior-posterior sliding pouch of Douglas, anterior compartment, posterior compartment, sacral ligaments, and rest of the abdomen? So, any comments on?
I'm wondering whether, because as I say, we all do our ultrasound ourselves. When you give a report, could you give snippets of videos of what you have done so that the
We do that very often. We give small clippings also on a CD or on a pen drive, especially when you have something positive like restricted mobility or something.
So basically, this is going to help us decide the extent of surgery, difficulty of surgery, to plan our surgery. But one thing, small bowel adhesions and difficulty to enter the pelvis, this will be never predicted by all these modalities.
Absolutely. So that is where I think MRI comes into picture, especially once you're talking of a sigmoid colon or small bowel, as you said, that is where your ultrasound probe does not have that field of view going beyond the rectum. You might at the most say rectosigmoid junction. And this is where probably I think MR plays an
No,
important
and
role.
in this one, when you have a report like this, how it helps you is that, many of us who do infertility, we also do endoscopies. Now, this type of a report is going to give us an idea regarding the type of findings you expect there and whether you're technically competent to tackle with these kind of things, because it's not every infertility specialist who can tackle all of this involvement. There are few, but the others can't. And the worst thing to do for an endometriosis patient is to do an incomplete surgery
Absolutely.
because of lack of competence. So I think that is where this kind of reporting is why we should change. When we see something, we should be open to suggestions as to why we should be changed.
Both.
Because we see many a times that incomplete surgery, the first surgery done on an endometriosis patient many a times is the most important surgery. So I think that is we take the essence from the discussion that why it's important.
Just one doubt. There lot of times they report hydronephrosis, hydroureters. So then you showed one nodule in the ureter just recently. So sometimes it will be just puckering of the retroperitoneum which is compressing.
Possible,
How do you
absolutely.
distinguish the same? How
Yeah,
well
I
can you
mean,
distinguish?
if you don't see the nodule, then indirectly it would mean that the ureter is somewhere, there's some adhesion or a fibrosis or scar at that end. I think we in our institute, besides this, whenever, especially when there's a finding like this, we would go for an MRI also because that
No, and,
or a CT can also show that.
What Shaijas says is just telling is, sir, you are doing this so nicely as though a gynecologist is improving, probably because your wife is a gynecologist, so you're forced to do this.
Yeah, I improved because of her. That's okay.
Your wife has kept you on your toes.
Absolutely. And we have good interactions. Fortunately, we have very good friends and
And probably you get the correlation.
we
See,
have
very
friends and
important.
critics. I think it is very important to have critics.
No, and you're getting the correlation, sir. Many
I'll
times
show you
what
one
happens,
case,
yes.
like at the end, yeah. So we'll see one
No,
case.
Can I make
yeah,
a
yeah,
suggestion?
sorry.
With ultrasound, with what you have shown, all the signs at the bowel, one of the things that I have problem with is which patient will need bowel resection, which patient will need disc resection. Can you tell whether that can be done with our ultrasound? Another thing is there are people in the world, I think someone in Sydney does that, who actually can look for
Layers of the bowel.
they
Layers
look
of
for sigmoid colon endometriosis and cecum endometriosis. How do they do that?
So so cecum and sigmoid we need to do MRI. For the type of resection, I think we can now see layers of bowel. So we can see whether it is serosa, muscularis, submucosa, up to what level it is involving. That much we can do on a rectal ultrasound. But one thing, anything which goes beyond the vision of a transvaginal probe, as we know, it has got a limited field of view. I mean, that is where MRI. In us and in Jaslok, what they also do for MRI is they borrow our ultrasound jelly and they put the ultrasound jelly, a lot of ultrasound jelly in the rectum, and that acts as a negative contrast for them. So that's a good idea. So as we have been saying that don't dive without judging the depth of water. And I'll show you one case, just how we sort of correlate with the surgeon. So this was a frozen pelvis, of course. So we said there is right endometriosis.
Can I just disturb you for a moment?
Yeah, sorry.
My train is there.
Oh,
so
sorry.
I'm
Yeah,
leave-
please.
So
I
thank you
think
so
we are
much.
winding up.
Yeah, before that, just wanted to put across a word that it's great to have such an imaging person who's actually thinking of what difference he can make to the person who's actually reading it, rather than being just methodical and writing a lot of things and just leaving some report there. I think we really appreciate. And if your wife has contributed to this, I think special regards from us to your
I'll
wife
tell her that.
for making life very easy for the surgeon in the gynecologist. So thank you so much, sir, on that
Thank you.
note.
Thank you.
Thank you, Selva sir, and thank you to
Yeah,
all
it
the
was fun
co-panelists.
reacting with all of you. Every time we learn so much from the clinicians, absolutely. So just last case. So we said, like in this case, there was a right ovarian endometriosis and left. So there was a right endometriosis and a left endometriosis. We said there is a right hematosalpinx and again, we said hydro or hemato, but nonetheless, both the tubes were affected. We said there is a uterosacral involvement, so there was a left uterosacral involvement, and we said there is a rectal nodule, there was a rectal nodule, and we said there is a sigmoid nodule, and there was a sigmoid nodule. So, Hemant called me up from the OT, and he said, Nitin, whatever you said was, perfect. So for him, as all of you say, for him also, he was planned, he knew this is what he's going to encounter, he was ready for it. The Ninan was assisting him, was ready for it. And so I think this interaction and learning, because it's a vast thing, we have to learn from each other, is what will help us in future. Thank you so much. Would you like to say some ending words?
I mean, I wish we have a person like him in
We are
our
all
country
thinking
as
the
well,
same.
so that
We
we
are
can the cases that we have trouble with, we can ask you to help us to interpret.
See, we are forced to do our own because if we had somebody like you, we would never, I think we would have left everything to you.
Yes, yes, exactly. That's fine.
Thank you so much, all of you, panelists.
Okay, thank you, thank you.
Thank you, moderators and panelists, for such an engaging and insightful discussion. With this, we are pulling down the curtains on the academic sessions as part of the Advances 2025. Thank you all the delegates who have been a part of this all 3 days. Now is the time for a picture. Thank you, everyone. Thank you so much. Kindly wait for a couple of more minutes so that we will be starting our valedictory function soon so that we can end the celebration all together.